Good afternoon, everyone. Hello. It's so nice to see such a great turnout. My name is Paul Helft. I'm the director of the Fairbanks Center for Medical Ethics, and I'd like to welcome you here today to our combined session with our colleagues in Risk here at IU Health. So it's a great pleasure to welcome you. Just a quick announcement, if you didn't RSVP and sign up for lunch, there are apparently extra lunches if anybody would like to run out and grab that, I've just been told. Please make sure that you signed in at the table outside. That'll help us to track attendance, and it's also how you will receive continuing education for the session. So we record and broadcast our lectures. You can find a whole historical series of our lectures on our website, fairbankscenter.org, if you'd like to link to them. I'd like to thank everyone who joins us nearly every month from IU Health Ball Memorial, from West, North, Arnett, Blackford, Paoli, the Child Life and Creative Art Therapies Department at the Peyton Manning's Children's Hospital at St. Vincent, and Reed Health most recently. So please remember to silence all your electronic devices, and if you need to return a call, please leave the auditorium just for the sake of listening. I want to thank IU Health Risk Retention Group for co-sponsoring this lecture and for providing lunch. Our speaker has no relevant financial conflicts of interest to disclose. So it's a great pleasure to introduce to you Susan Boisvert. We went and practiced her last name. Susan is a senior risk specialist for Coverys. Her primary responsibilities include providing on-site assessments and risk management services to insured physicians, hospitals, and facilities in Maine, Massachusetts, and New Hampshire. I would recommend to all of you that you visit those places if you ever get the opportunity to do so if you haven't already. She is a registered nurse by training, has a master's degree in health services administration from St. Joseph College of Maine, and a Bachelor of Science in nursing from the University of Connecticut. She's a certified professional in healthcare risk management and a fellow in the American Society of Healthcare Risk Management, or ASHRM. Sue is past president of the Northern New England Society for Healthcare Risk Management. She's a peer reviewer for ASHRM Journal of Healthcare Risk Management and serves on the Advocacy Task Force, where she focuses on health information technology and transgender concerns. She's a frequent presenter at regional and national conferences and contributes to healthcare and risk management journals and publications. I wanted to personally thank Katie Dufresne, one of my old colleagues and friends, for arranging all of this and for finding Susan and allowing her to come today to speak to us. So we're really looking forward to your lecture.
Thank you.
Thank you so much.
So I want to make sure you can hear me all right. Thumbs up. All right, great. Let's get started. So here's what we're going to talk about. My slides are possessed. Here's what we're going to talk about today. Healthcare risks experienced by transgender patients, the difference between sexual orientation and gender identity, and some strategies. So he said I have no financial relationships, but I do want to disclose that I'm a heterosexual, cisgender female, and my preferred pronouns are she, her, and hers. Some of you may think, wow, that's too much information. It's important, and you'll learn how important this is as we move through the program. I put together a PDF of resources for you, all sorts of great transgender study results and resources that you might be able to use in your, whatever your practice area is. It's a PDF because there are links, so make sure, if you're interested in that you get a copy of it. And then the other thing I wanted to talk to you about is I am a risk manager. So you know how you're never given a problem that's bigger than your ability to deal with it? Maine's a pretty wide open place. We have a pretty small population, and anything goes as long as you don't hurt other people. And so about 12 or 15 years ago, I started getting questions from physician practices about people wanting to change the sex in their medical record and wanting to change their name, but wanting to change it from a male or female name to something other than that. And I thought, wow, that's kind of an interesting situation. So I learned a lot about it, and I helped my practices. And in 2011, my husband and I sent a daughter off to college. And we had the same concerns that all parents have when they send their kids to college. You want them to do well, but you want them to be happy and integrate and make friends and things like that. And so things weren't really going very well. And our daughter wanted to stay, I just gave it away. Our daughter wanted to stay in Maine, and we said, no, you need to go out and see the world, please. So we found this great college in the middle of nowhere, New York. And we just weren't getting good vibes. So spring break came, the daughter came home and said, I got to talk to you guys about something. And I thought for sure it was going to be I'm dropping out of school. And so I was prepared for that. Never in my wildest dreams did I think I would hear, I'm a boy. I've known it for a really long time, and I want you to know I've started testosterone. Well, I'm a mom. I cried, and I said, what did I do wrong? And fortunately, my son is a lot more mature than I am and said, Mommy, this isn't about you. Way right answer. Snapped me right into nurse mode. And the nurse in me, anybody who knows a nurse knows what nurse mode is. The nurse in me said to my husband, wow, that they have very high suicide rates. This is the most important thing we're ever going to get right as parents, and we have to get it right. And that put me into risk manager mode, back where I was when my practices first started asking me about this. And I researched and learned everything I possibly could, and collaborated with my kiddo and the friends that he eventually made when he was firm in his decision. And then I realized that healthcare is so far behind in this topic. None of my peers knew anything. And so I thought, I'm going to start speaking about this. And so that's how I ended up here. So I will tell you I'm a mom, and that makes me biased. So please don't hold that against me. I am going to try to be as objective as possible, but I'm definitely biased on the topic. So I love this slide, the genderbread person. The first time I saw this, I thought, I am going to use this in every presentation. It's chipper, cheerful, non-threatening way to explain very difficult concepts. So what we're looking at here is the concepts of gender identity and sexual orientation. And they are not the same thing. A lot of people get them confused, but they're not the same. And everyone has a gender identity and a sexual orientation. And I told you mine. My sexual orientation is heterosexual, and my gender identity is female. So looking at the genderbread person, let's start from the top down. So that lovely rainbow brain is gender identity. That's a person's concept of themselves in terms of gender. We tend to think about it in terms of maleness or femaleness. I'm making air quotes on purpose because it's really broader than that. And then the next step down is attraction. That's sexual orientation. That's who people are romantically or sexually attracted to. And then there's sex. And sex is biology. That's the male or female. And we're going to talk more about that because none of these concepts are as simple as they seem. And then the dotted line on the outside is expression. So when you think about gender identity, you have to remember that the person has a sex assigned at birth, the person has a gender identity, and then the person expresses. And they may express as their gender identity, or they may express as their biology. I'm expressed as a female today. Or they may express gender neutral or androgynous. Honestly, I would love to express the androgynous when I do these presentations, but when I'm representing my employer, they have some guidelines about what we're supposed to do. So that's the genderbread person. So now let's get a little bit more specific. This is a binary world, day and night, black and white. We tend to look at things in binaries. Sex and gender identity are not binary. So it's the 21st century, and when we sex an infant, we still do it by looking. Nothing else in medicine is that basic. And that's how we determine male or female. But it doesn't always work that way. 1 in 1,000 individuals cannot be defined as XX or XY and may or may not have external genitalia that are clear and may or may not have internal organs that are clear and may or may not have hormones or biochemistry that is clear. So it's not binary, and we need to start moving away from that concept. And gender identity is not binary either. We already talked about it's how an individual perceives their maleness or femaleness. So I'm cisgender. My gender identity is the same as my biology. And so when you think about the opposite or the alternative to cisgender, from a cisgender perspective, we think transgender. And when we think transgender, we think male to female or female to male. But you see how that's another binary? It's really broader than that. There are way more options. So in addition to transgender, there's agender, and those are people who refuse to be labeled in those terms. There's also gender non-binary, gender non-conforming, gender neutral, gender fluid, gender queer. Gender fluid and gender questioning are terms that are usually applied to children and adolescents who, it's common for kids to sort of play around with gender identity. That doesn't necessarily mean they're going to identify as something other than their biology, but some of them do. And queer is a term that members of the community apply to themselves. You have to be careful about using that term. I would never use the term queer to describe anyone when I'm talking to them unless I had been given permission to do that. My favorite, though, is two-spirit. So think about native populations before, as they existed in the past. Many of them, in fact, almost all of them, had more than two genders. There was a third gender, and the Native Americans call it two-spirit. And those people were highly revered. They were considered wise. They were sought, their input was sought on important decisions because they had a broader perspective. So in the 21st century, what has happened to all of the two-spirits? What happened to them is what happens to every native culture, colonialization. I mean, I know that's kind of a harsh thing to say. That's all I'm going to say, but there's tons of literature to support the fact that this was repressed in the cultures when they were incorporated into the cultures that moved into their territories. So it's not binary, and you need to keep a really open mind. So this is my son, and this is a bathroom selfie. Does anybody know what that is? Yeah. It's the transgender community's nonviolent response to states that tell you you have to use the bathroom of your biology. So he's got a smirk on his face because he's in North Carolina in a bathroom. But we're from Maine. He's already changed his birth certificate and his name and his driver's license. So even if the bathroom monitor checked, they can only check ID. They can't check biology. They don't have hoo-hoo checkers. So bathrooms are a unique challenge, but let's talk about the serious challenges. So in 2015, a very large study of transgender individuals was conducted. It was actually kind of a redo of a study done in 2011. The 2015 study used some of the CDC behavioral risk factor surveillance criteria so that we could compare data. Anyway, they asked questions about all sorts of things, but these are the healthcare responses. So the question usually starts with, in the past year, have you? 33% reported that they were verbally harassed in a healthcare setting or refused medical treatment. And some of them were actually sexually assaulted in a healthcare setting. And we're talking about 2014 here, so this is not the distant past. 23% avoided seeking care for fear of mistreatment. Perhaps they know somebody in the 33%. And 24% had to teach their provider about transgender care. Had to teach their provider about transgender care. Think about that. So I am magical, and I've just given all of you heart disease. And tomorrow you're going to go to your doctor and you're going to say, I think there's something wrong with my heart. And your doctor's going to say, I don't know anything about heart disease. You're going to have to find somebody else. That's basically what 24% of the people who responded to the survey, and I neglected to tell you that there were almost 28,000 respondents to the survey, 27,700 plus. So any of you that are involved in research, would you not salivate for an N that big? I mean, we're talking huge numbers here. But here's where the rubber meets the road. 40% admitted that they had attempted suicide at least once. 82% of them said they had seriously considered suicide. And so the transgender survey was really an adult-based survey. There are other surveys of children and adolescents, and the numbers vary pretty widely, and we're going to explain why I have squishy data around transgender patients, but around 54% of kiddos will admit to attempting suicide if they're rejected by their healthcare providers, their family, or their school is unsupportive. So 40%, 54%, 82%. Why is this not a public health crisis? If these numbers applied to any other thing in healthcare, we would be all over it. So ask yourselves that. So transgender discrimination, they have their own unique discriminators, I guess. So maybe these two vocabulary words are new for you, but think about discrimination on a spectrum. And this is the naughty spectrum. And so on one end of the naughty spectrum, we have cisnormativity. And that is, my cisgender perspective is correct, and it's superior to a transgender perspective. And we see that everywhere in everyday life. Male and female bathrooms, male and female clothing, male and female toys. So I showed you the picture of my son. He's 5 feet 1 inch tall, and his female shoe size was 6. Can you imagine trying to find a man's shoe that small? It's impossible. We buy Vans. Hooray for the win. They're agender. Not that I'm telling anyone they should purchase Vans, but they do have a wide selection in every size. And so that's cisnormativity, and it's everywhere. And then there's transphobia, and that's the other end of the naughty scale. And so before I get to transphobia, because some of you are going to have a hard time with this, let's start with the kiddo in Texas, the affluenza teen who was intoxicated and was in a motor vehicle accident, killed 4 people, and his defense was, I was raised in a wealthy household and I can't be held accountable for my actions, okay? So the transphobia defense is, when I found out that person was transgender, I just couldn't control myself and I had to kill them. And it has been used in court. I'm happy to say it has not been used successfully. But transphobia is an irrational fear of or aversion to transgender or transsexual people, and is often used as an excuse for violence against transgender people. So these are both naughty, and transphobia is really, really naughty. And if you have any of those sort of inclinations, I encourage you to see a behavioral health professional. Seriously. So discrimination has negative effects on people's health. And this is not a transgender study. This is actually a summary of a bunch of different studies of the effects of discrimination on patients in general, elderly patients, disabled patients. There were probably transgender patients in there, but we don't know, and I'll explain that in a few minutes. So first of all, they have decreased patient satisfaction. I had to put that up there because is that a surprise? Would anybody be satisfied if they were discriminated against? But they also have negative self-care behaviors. They don't go to the doctor. They don't get their prescriptions filled. They don't get their lab work done. They don't have their cancer screenings. They don't see a primary care provider. This is not good for the patient's outcome. And when I speak to hospitals, executives, I say, If you're not willing to provide transgender care because it's the right thing to do, if you're not willing to make sure that you're gender affirming, I'm going to appeal to your pecuniary nature. These are the things that if you're in a risk-sharing arrangement like an ACO are going to hurt your bottom line. So here are the reasons why you need to do a good job providing transgender care, even if it's not what you personally believe in, because it's how you remain successful in the healthcare business in the 21st century. The most singular challenge faced by any patient demographic, though, is invisibility. Transgender patients are invisible. They are not reflected. Gender identity is not reflected in the federal census data. We don't know how many transgender people there are in the United States. We don't know how many transgender people there are in Indiana. You don't know how many transgender people there are in Indianapolis because we don't count them. One state did a transgender census. It was done in 2012. But honestly, transgender people are discriminated against in many states. It's not really safe for them to say they're transgender. How many of them are going to sort of own up to it on a census? So there's no national data. The Williams Institute has done a lot of work, and the work they've done has been generalizing the data from the CDC Behavioral Risk Factor Surveillance System, so down under public health data. The problem with that data, first of all, it's only measured in 28 states, and it's behavioral risk factors. Isn't that kind of a skewed data set in the first place? You're sort of assuming that transgender is a behavioral risk factor. We don't collect it in crime statistics. No, it's not in the FBI database. It's not in the state police databases. It's not in the city databases. And why is that a bad thing? We don't know the kind of crimes that transgender patients are subjected to. How do we know the most dangerous thing in America to be is a Black transgender woman? How do we know that? We know it because the transgender community collects those statistics. That's kind of sad, if you ask me. It's a demographic that needs to be considered, because we, what viable argument did the transgender people have when the whole bathroom thing came out and it wasn't safe for women and children to be in a bathroom with a trans woman? Well, I think they're probably safer than the trans person is, but there are no statistics. We don't know, other than what the transgender community collects. You're not a person if there isn't data around you in our society. But the big one for healthcare, who is the largest healthcare payer in the world? The US government. And there's tons and tons and tons of data. And anybody in this room who's doing any research in healthcare has probably used some of that. There's no third-party payer data on transgender patients because we don't collect gender identity. They're invisible. So my next question as a risk manager is invisibility a patient safety concern? Well, I wouldn't ask you if it wasn't. So what happens when there's a lack of data on a demographic? How do you do population management if you don't know whether or not the person's transgender? You can't. What about strategic service planning? I mean, let's face it, there are hospitals that aren't really interested in serving this demographic anyway. And if there's no numbers to say there's 50,000 transgender people in your greater service area that aren't currently being served, if you don't have that kind of leverage, how do you get the services provided? Can I just tell you that any organization that started a gender affirmation surgery program has waiting lists that are more than a year long? That's the kind of data that we have. We don't have real numbers. How do we identify healthcare disparities? I mean, this is an ethics conference. That's kind of an ethical issue. How can you identify the disparities if you can't identify the population, right? I mean, that's kind of significant. But you're all professionals, and you all practice evidence-based whatever, evidence-based social work, evidence-based nursing, evidence-based medicine. How can you do that if there's not an evidence base? We cannot do retrospective studies on transgender patients. So we can't determine things like the long-term effects of hormone therapy, or whether or not we're managing gender dysphoria appropriately, or whether or not we're providing appropriate age-specific care. So I have a question for you. I mean, we're going to talk about pediatric and adult, but I want to talk about geriatrics. What is appropriate geriatric care for a transgender patient? Who do you think is the single largest demographic getting gender affirmation or gender reassignment surgery? It's geriatric patients. And why do you suppose that is? I mean, who knows? We would have to ask them, but I suspect they finally have the resources and the freedom to have it done. So here's another question. I am going to go through menopause, as many of you, and there's even sort of a male version of menopause. Do we do that to transgender patients? Do we take their hormones away so they have menopause like the rest of us? I say for the win, transgender. You don't have to go through that. But these are the things that we have to think about, right? And we don't know the effects of hormone replacement therapy on chronic disease, and that is a real problem because there are a lot of specialists who will say, I am not going to provide care to a transgender patient because I don't know how their hormones are going to affect their disease. So there are not evidence-based, but reports of transgender people who have died waiting for an oncologist to care for them. There are behavioral health programs in large centers on the East Coast when they are treating transgender patients for significant mental illness, stop their hormones. How is that going to help? But we have no science to support or argue against that. So invisibility is a true patient safety concern and a human rights concern and all the other concerns that you can think of when you think about ethics. So we have to get gender identity in the record. And we have to get preferred name and pronoun in the record as well. And so I'm a risk manager. When I go out to do assessments to see how organizations are doing, I look for workarounds because the workaround is the symptom of something that doesn't work. So here I am standing in front of you guys in a very esteemed academic setting telling you that you may have to develop a workaround to get gender identity into the electronic medical record and into the demographics. And why do I tell you that? Because the benefits way outweigh the risks. So there are some, I don't imagine we have many IT wizards here, but these are the things that your IT wizards can do if you're not able to already reflect gender identity in your medical records. The problem with it is, it's been, so the federal government has guidelines for interoperability, computers talking to each other. And one of the things that has to happen is the demographics have to be the same. So they have standards for reflecting sexual orientation and gender identity in the records, and they've been in place since 2014. The issue is making them mandatory keeps getting pushed off. And electronic medical records are commercial products, and they're proprietary, and there's no incentive for the vendors to make this happen. So there are very few vendors who have done it. One of the vendors who has done it and has done it well is Epic, which is fortunate because it's one of the largest vendors. The issue is it's not turned on. So even if you have Epic, you may not have the ability to reflect gender identity because that module isn't turned on. Why do you suppose that module is not turned on? Because asking someone their gender identity, that's not something that you're going to implement overnight. There's a lot of groundwork that has to be done. How is the question going to be asked? Who's going to ask it? It's very complicated. I mean, you know, we have registration clerks asking these questions. There's a fair amount of training would be required. You have to give them the problem-solving skills to handle a person who might be angry at the way that question was represented. So it's not an easy thing to do, but it's a worthy task to undertake. I want to talk about why it's so important to use a transgender person's preferred name and preferred pronoun. When a person transitions, they become the person that they've always wanted to be. And don't we all do that? I mean, we grow up. When you were an adolescent, did you think you were going to be what you are now? I mean, we all go through this. And so that name that they had, the legal name, and not everybody lives in a state where it's easy to change their name or has the resources to do it. And can I tell you, some states still require sexual reassignment surgery before a transgender person can change their name. Who else has to have something cut off to change their name? It's absurd. Sorry, I mean, I told you I was a little bit biased on the subject. So when they have their new identity, their old name, the name that their legal name, the name that they had at birth, is their dead name. That's the person who they used to be. And so when you use their dead name, it's harmful to them. It's painful, and they call it deadnaming. And the same thing when you use the wrong pronoun. Not only are you misgendering that person, but it's painful. And the reason that I have a big picture of bees up here is not for people who are afraid of bees, but my son said, I asked him about it. I said, what's the big deal it's really convenient for me to have this excellent resource. And I can ask him questions like that. So I said, what's the big deal with using the wrong name and wrong pronoun? And he said, Mommy, you need to think about it like a bee sting. 1 or 2 bee stings hurts, but a whole bunch of bee stings can kill you. And you know, that's not hyperbole. Any of you that are on Tumblr, just Google transgender art and see some of the artwork that these kids do around what their life is like and how they feel when the wrong name and pronoun is used. And have a box of Kleenex handy. I'm not kidding. It's very moving. So you got to ask them their preferred name and pronoun. You got to figure out how to get it in the record, and you have to use it. And you have to use it when you're talking with them and when you're talking about them. And if you make a mistake, apologize. And just apologize once. Transgender people say, don't make it a thing if it's not a thing. The name tags, so I did not take this picture, but when I saw it, I just loved it. So these are different name tags, and this gives you an idea of pronouns. So, you know, I told you my pronouns are she, her, and hers, and male pronouns, he, him, his. So there are gender-neutral pronouns, and you know, the first ones that pop to mind are they, their, and theirs. The problem with that is it's plural. It's not bad grammar anymore, though. I can tell you the AP Style Guide used by reporters and writers of all ilk, it's now okay to use they as a singular pronoun. It's really, it does kind of complicate things. Just personal example, you know, my son will call me up and say, he has lots of gender fluid buddies, and he'll say, Lou is coming over and there, and I'm thinking, okay, so is that there just Lou, or are there a whole bunch of other people coming, and do I need to make sure I have enough food for everybody? So there are other options down below. I would say those are sort of probably within the community as opposed to widely used, but you could get pronouns that you're not used to. I'll just tell you a funny story. Sometimes my son and I speak together, and so we were speaking to an audience in a state that is not friendly to transgender individuals. Not to say that the audience isn't, but and he was talking about how important it is to ask a person what their preferred pronoun was. And so this person in the audience raised their hand and said, well, you think we should ask everybody what their pronoun is? What's my grandfather going to think? And my son said, well, I'm pretty sure your grandfather knows what a pronoun is. Good answer. You know what? The first couple of times it's going to seem odd, but after a while it's going to be normal and people are going to expect it, and that's how you normalize things, right? So I collect bathroom signs because I'm weird like that. And so here are some of the signs that I've collected. And the one on the left, the bathroom is a severe weather shelter. And this is from an airport in North Carolina. So I thought that was kind of ironic because I'm pretty sure a transgender person isn't going to take shelter in a bathroom in North Carolina. They might now, but the one in the middle is from the Detroit Metro Airport. So reserved for the elderly, disabled, or families with small children. So that's kind of okay if you stop there. That's kind of an ah. But then you add the only. So stop and think about that. That restricts everyone in this room unless you're disabled. Most of us probably don't meet the category of elderly. Some of us might, and you don't have small children with you. So none of us could use this bathroom. The one on the right is an all-gender restroom, and that's not from an airport. I wish it was, but it's not. It's from Boston Medical Center in Boston. They have a gender affirmation program, and I really like it. So this is kind of, if you don't already have these in your organizations, it's not a bad example. My absolute favorite one is from Vermont. But when I speak outside of New England, I don't bring my Vermont sign because we know you guys think we're crispy. So the Vermont sign is from a bar, and there's all sorts of stickers, Ben and Jerry's, you know. And right in the middle is this sign that says, "We don't care." Hooray, that's the way it should be. Another challenge that faces transgender people is a misunderstanding about what it means to be transgender. Being transgender, having a gender identity is not a disorder. We all have a gender identity, okay? But you need to have a diagnosis in American medicine to get treatment, right? You need to have a diagnosis to get medication. You need to have a diagnosis to get your care paid for. So this is sort of a history of the process. So in the previous edition of the DSM-4, if you don't already know, it's the diagnostic manual for diagnosing behavioral health concerns. There were two choices: body dysmorphic disorder, which really doesn't apply because it's more about eating disorders, and gender identity disorder. But it's not a disorder. We all have one. But it was a great effort to include an underserved population. So in the next iteration of the DSM, we have gender dysphoria, and that really is a thing. Not all transgender patients have gender dysphoria, but many of them do, and when they have it is when they're realizing that they're transgender, and they haven't been able to achieve their desired gender identity. So there's a disconnect between what they perceive in their brain and how they're sort of perceived by others. And so, gender dysphoria. And untreated gender dysphoria is one of the reasons, or inadequately treated gender dysphoria is one of the reasons the suicide statistics are so high. What we're thinking about in the future, though, what is being discussed in many sort of different segments of healthcare is that, yes, transgender people have dysphoria. So do lots of other people. There are a lot of cisgender people who have dysphoria. It may not be gender related. It may be related to something else. But that's not the underlying issue, really. The underlying issue is that they have the wrong hormones, right? They need to have their hormones kind of corrected. And so that's really more of an endocrine thing. And so it's possible that that transgender, the hormone sort of disconnect will be considered an endocrine disorder like diabetes or other endocrine disorders. So that's possibly the future. And we do need to have a diagnosis, so Blue Cross will pay for the things that transgender people need. So let's talk about gender affirming care. For pediatric patients, there's hormone replacement therapy, but you don't want to do that until they need hormones. So what do you do with a kid that's, say, 9 or 10 and is persisting in a gender identity that's different than their biology? Do you let them go through puberty? And what's going to happen to that person? They're going to go through the puberty of their biology, and they're going to have all the external representations of the wrong gender. So that's why my son is 5 feet 1 inches tall and had, unfortunately for him, he was very well endowed in the bust. That's horrifying to kids, by the way. Even sort of kids who are cisgender don't really want that when they're that young. Anyway, so what do we do about that? Do we make them go through puberty twice? I mean, you guys all went through puberty. Did you enjoy it? Would you want to do it again? No, trans people don't do this because they want to. It's kind of it's not really a choice. They have to. It's sort of determinism in a way. So we need to give these kids time to think. And sometimes it's not the kids that need time to think. Sometimes it's the parents. And so we do that by suppressing puberty with gonadotropin-releasing hormone. They're really analogs, but you'll see the term analogs or agonists. So what they're agonizing, what they're blocking are the actual hormones that induce puberty. So they're stopping puberty. And we use Lupron or Hysterlin. And so those drugs are used for many other things, like premature onset of puberty. There's a fair amount of, since we don't count gender identity, we can't look at transgender specific, but there's a fair amount of other literature on the use of these in kids, and it's quite reversible. Once you stop it, they either go through the puberty of their biology, or we do hormone replacement therapy and they go through the puberty that they desire to go through. It's really fairly safe. It's horrifying to people who have not heard of it, though. So it's really an ethical dilemma. From a medical perspective, I can easily tell you that the only thing that we see in kids who have their puberty suppressed is issues with their bone density. But what we don't know is, do kids have issue with their bone density anyway? I mean, we know their bones, green stick fractures, we know their bones are largely cartilaginous, and we know they're going to mineralize as they get older. So are there long-term consequences to the trans kids who have their puberty suppressed and have low bone density while we don't know, right? This is another one of those studies that we need to do. The other thing that's important to realize is that hormone replacement therapy for these kids can be life-saving. So their dysphoria can be so great that if they do not receive hormone replacement therapy, they may mutilate themselves or they may kill themselves. And so to the point that sometimes when there's the discord in the family and the parents and the kids are on completely different pages, the child will be removed from the home and placed in a safer setting. So let's talk about that safer setting for a minute. Who do you think the state, when they remove the child from the home so that they can undergo the treatment that's going to hopefully keep them alive, who do you think those kids are being placed with? Do you think somebody said it, grandparents. It's not the aunts and uncles, it's the grandparents. How amazing is that the grandparents in our society are more welcoming and supporting to their transgender family members than their own parents are. Anyway, so let's move into adults. They get hormone replacement therapy. Testosterone is a mighty thing, so it has to be suppressed with an anti-androgen and then estrogen. Female to male transgenders just take testosterone, and then they may have surgeries. And in the transgender community, they refer to the surgeries as top surgery and bottom surgery. It's pretty common for transgender people to be interested in top surgery, and it's actually, if you're fortunate enough to have insurance that covers it, the paperwork that you have to go through, the pre-surgery paperwork for top surgery for Blue Cross Blue Shield of Massachusetts is 46 pages long. The bottom surgery paperwork is 148 pages long. And it's a lot easier to get the top surgery. Not all transgender patients want bottom surgery, and so there's, that would be gender reassignment, male to female or female to male. The male to female surgery is more advanced. There are more practitioners, there are more places to get it done, and it has better outcomes. The female to male is less advanced. There are fewer centers to do it, and the outcomes are not as good. So, more work needs to be done in that area. And the other thing is trans women, so a male to female transgender, if they have gone through puberty as a male, they're going to have an Adam's apple that they may want to have shaved down. They may want to have work on their cheekbones. They may want to have work on their lips and on their chin. There are all sorts of other procedures that they may need to reflect their desired appearance. And it's very difficult to find providers who can do that, and even more difficult to get them paid for. So I think I want to give you guys time to answer questions, so I'm going to kind of buzz through these. So suicide risk is really huge. I just wanted to put it in context for you. So 54% of kids who are gender fluid and experience rejection compared to a population average of 8%. So that 8% is kind of in the middle, but the highest number I've ever seen for pediatric suicide is 11%. So we're still talking 5 times higher, 500% higher for this population. We talked a little bit about self-mutilation. You know, adolescent kids sometimes cut themselves. Adolescent transgender kids sometimes cut things off. And you need to be aware of that. And if you work in any kind of emergency care or urgent care, you need to sort of be prepared. You might see a patient that's happened with. They have very high incidences of substance abuse, smoking and drinking, high incidence of homelessness and malnutrition because they get kicked out of their homes, and they're very at risk for human trafficking. So what are we going to do about it as professionals? We need to assess them for gender dysphoria and suicide risk. You need to have a list of transgender friendly and skilled providers available. And they're not going to find these specialists. They're not going to show up at the transgender friendly. You need to have these lists available in primary care practices, family practices, urgent care centers, emergency departments, bathrooms, places where they can find them. You also need to have literature and resources for parents. I mean, I considered myself fairly open, but I did not, it took me a little while to accept my son's transition. And, you know, they have to have counseling, and you have family counseling. And honestly, the counselor probably never wants to see me again. I had some anger and some denial. It's hard for parents, even parents that are open, it will be hard for. The other thing is these kids are the weirdos, right? They're generally not the sports kids. It does happen sometimes, but so they may not have a large crowd of friends, you know, a real world support system. So where do kids go? Where do they spend all their time? They spend it online, right? And there are all sorts of really wonderful, welcoming places for kids online, but there's a lot of really bad people out there too. And these guys really need guidance because just think of the anecdotal stories in the press about trans kids who were bullied, cyberbullied to death. It's something that you have to consider. Adult risks are pretty much the same. The suicide rate for trans people, 40%, 0.6 in the general population, so still a huge difference. Adult transgender patients who can't get appropriate care may seek other avenues like street hormones. So, you know, testosterone used for transitioning is a scheduled drug, but testosterone used in veterinary care is pretty readily available. Do you want your patients self-treating with veterinary medications? They'll also sometimes do their own body contouring, and they'll go to the hardware store and get silicone and inject it, and they have parties, pumping parties where they inject each other. We don't want that. Why should people have to do that? You're so desperate you're gonna plump your cheeks with something from the hardware store? We should make this available. I mean, this behavior is them trying to get the care that they need the only way they are able to get it. It's not aberrant. It's sad. They're very high risk for domestic partner violence and human trafficking, and they have a terrible time finding providers that are willing to care for them. You know, I got to tell you this story. This blew my mind. I do grand rounds all the time, and I got invited to do a grand rounds in one of the big centers in Boston, so I was really nervous about it. So I'm doing my presentation, and I'm talking about, I was on the slide where gender identity is not a disorder, and one of the providers said to me, well, what's the difference between conversion therapy and hormone therapy? answer a question like that. But I'm a professional, so the first thing I said, well, one is really bad for you and one isn't. And then I thought, that's not a very good answer. This person is a scientist, so I said it's a spurious comparison. A table has 4 legs, a pig has 4 legs, therefore a table is a pig. It's mind-blowing, the lack of understanding out there. So the first thing you got to do, really with anyone, but especially with adults, because a kid is going to call you on it, you need to de-bias. You need to think about what your biases are. So what am I, as a cisgender person, going to say to this transgender person that would be perfectly normal for me to say to a cis person, but is going to be offensive to the trans person? So here's what I'm going to tell you. Here's the first one. I'm going to send you to an OBGYN provider. If you're a female to male transgender, you're going to think, what the heck do I need an OB for? And if you're a male to female transgender, you're going to think, does this person know anything about anatomy? But you are going to send them probably to an OBGYN, especially if you're not in a center, because that person is a reproductive endocrinologist and they understand the hormones and they're the perfect person to send them to. So how do you tell the trans person that you're going to do that? You say, I am going to refer you to a person who is expert in reproductive or in, hormone replacement therapy. You need to know that that person works out of an OBGYN office. And I know it may be uncomfortable for you to go there, but I can assure you that office is very comfortable taking care of trans people, and you will not, let me know if you have any problems in the office. So you've told them that you're going to send them to a place that they think that you're wackadoodle for sending them to, but you've told them why. And now they understand it and they're willing to go. And can I tell you, that's from personal experience. My son came back foaming at the mouth, and I said, wait a minute, there's a really good reason, they just didn't share it with you. That's transgender anticipatory guidance. So think about pediatrics, the parents. The kid starts toddling, the pediatrician tells the parents, okay, your kid is toddling. You need to get rid of heavy objects that they could pull down on themselves. You need to deal with the cords. You need to cover up the outlets. You need to do the same thing with trans people. What is normal to a cis person may be perceived as offensive to a trans person. So one of the things, if you're a primary care provider, you need to know whether or not the trans person has had surgery. What's there so you can provide appropriate primary care. But if you say, have you had the surgery, without any sort of preparation, that could be perceived as offensive. The person might think you're asking them what they have in their pants, and they're thinking that's none of your business. And you know what? 75% of the time it is none of your business. Don't ask that question unless you have a legitimate need to know. And it needs to be a clinical reason, not a curiosity reason. The rest of these we've already sort of talked about. If you have not got a flyer that has all of the transgender providers, so behavioral health specialists that take care of transgenders, reproductive endocrinology, surgery, top surgery, bottom surgery, all of those sorts of things available, you need to put one together because a trans person should not have to hunt hard for health care, and they should be able to have a choice. We have choice. If I needed a cardiologist, there are probably 100 that I could pick from. If I needed a reproductive endocrinologist, what if I don't like the one I get referred to? Don't stop at one. Here are some sort of take-home points for you. And I'm just going to show this quick because you'll have access to the slides. But here's what I really want to leave you with. Transgender patients are very loyal, and so are their moms. Word will get around if you do a good job. And you will have a whole new stream of patients. You need to be prepared for that. But the most important thing is you have the opportunity to change the narrative. You have the opportunity to reduce fear. You have the opportunity to prove to them that healthcare providers really do care about them and we really can do a good job. And you might actually save a life. You may not know that you've done it, or you may find out years later. But some of you who are not directly involved in resuscitative care, you still have the opportunity to make someone's life better or save their life. So when you think about transgender patients and transgender care, change their lives for the better. Help them change their lives for the better. So now I will take questions if you have any.
So the resource sheet that Sue has referred to a couple times, you will be getting that in your email from your sign-in. So if you sign in with your email, then you'll be getting that. So if you have a question, please wait for the microphone as we are recording. Anybody have a question?
I'll stay here a little while after if you're afraid to ask in front of the microphone.
Hi, thank you for that excellent talk. I'm not sure you can answer this because you imply that we really don't have the data. Do we have any idea the percentage of the population that are in this category?
So her question was, do you have any idea the percentage of the population? So it's really, really hard to say. What I will tell you is that one of the resources that I gave you in the handout is the Williams Institute report, and they have actually broken it down by national and state by state. I was naughty and didn't look up Indiana, but I can tell you that in Michigan, the sort of proposed transgender population is 40,000. That's how many there are in Massachusetts, and that one was actually confirmed by a census. So less than 1%. But they still need to be taken care of appropriately. Really good question, yes.
This isn't a question, but sorry, not a question, but just to follow up on that incidence. So I take care of a lot of transgender folks, but if you think of the incidence of transgender patients as similar to type 1 diabetes, that'll kind of blow your mind, right? Because we think of type 1 diabetes as pretty common and everybody is familiar with it. So it's just not super rare.
Right. Very good. In case you didn't hear that, she said, consider the incidence of transgender patients similar to the incidence of type 1 diabetes. It's not that rare. Other questions, comments, suggestions? Yes. Oh.
I'm a transgender woman. And the reason I'm here is because Dr. Cavigan doesn't know any better. She's been my endocrinologist since June of 2015. First of all, thank you so much for getting through your anger and your denial. I had to do it the other way. My wife had to grasp all of this. My gender issues erupted into gender dysphoria in 2013. Although I experienced them virtually all my life. I'm 60. I know I look 45. And I have 4 adult children. And at the time, all 4 were married, and I have 7 grandchildren. I'd like to gently correct you about one thing, very gently. Not everybody with gender dysphoria wants to become the gender that, I'm a genetic male, and I did not want to become a woman because I had 50-some years built as a man, and I was a husband and a father and a brother, and my parents are gone, but all of that freight and all I wanted in life. The very first time I ever saw Dr. Cavigan, I bawled through 20 minutes of telling her my life story. So not all of us want to transition or become this thing, even though in our mind it's like, all my life I said, all I want is to be a girl. And yet I have fully transitioned. Who knows Dr. Sive Gallagher? 51 weeks ago, April 11th last year, she did my bottom surgery. The woman is this is going to sound crass. If I sat down and a healthcare provider only saw my bottom, they probably would automatically take me as a genetic female. That's how good her work is. And my health is phenomenal, and I'm a runner, and I run more smoothly than ever. Well, that was crass. May I make one more point?
Yeah.
I used to be a Lutheran minister, and I'm used to a crowd, and I love to make people laugh. One final point, unless you let me go on for 45 minutes. 2 more points, quickly. On the pronouns. I had vocal cord surgery, but I'm struggling with using my new voice because it sounds so unnatural to somebody so old as I. But the higher my pitch, the clearer my voice comes out. So I usually talk like Greg and not like Gina. My voice gets me in trouble with the pronouns. Even though I present this way, I get the he pronoun all the time. And that's very discouraging. And before I had my name legally changed 2 years ago, they would make notes. This person goes by Gina, not Gregory, and so forth. And I'm sitting in an eye specialist office dressed like this, and they called for Greg Eilers. And I had to stand up, and as I walked across past 15 people, had to say, it's Gina, and then saw that it was written in big letters across the top. Names and pronouns, I beg you, pay close attention, because they are like bee stings, like crazy. Finally, my wife and I moved here in 2014. I have seen Dr. Cavigan and Dr. Gallagher and Dr. Parker for my voice, and I've had facial feminization surgery. I've had the chin and the forehead and all that kind of stuff done. Dr. Barry Epley for that. And I've had blew an eye out and had cataract done, and I had to have a tooth done, and I have a cardiologist. I have seen just about everybody. And this town is amazing. You folks are taking such good care of us trans folks. I have had 0 people, from receptionists to nurses to technicians to doctors, who has done nothing but taken good care of me. And so thank you so much. And just treat us like regular people. Just treat us like regular people, and we will be in good shape. Thanks for letting me go on. I'm so sorry.
That's all right. So just to follow up on what you said, great article in JAMA Ethics last year. They devoted a whole edition to transgender care. And this is a quote that I have starred. So this is a trans blogger. Nobody really wants to be a trans woman, i.e., nobody wakes up and goes, whoa, maybe my life would be better if I transitioned, alienating most of my friends and family. I wonder what'll happen at work. I'd love to spend all my money on hormones and surgery. This is their life. Thank you.
Thank you, everybody.